Welcome to our next segment, and welcome back to our panel.
In this section, we're going to touch on maintenance therapy, and we're going to go around the panel here and ask them what is their preferred regimen for maintenance therapy post-transplant for transplant eligible, standard risk, and high risk disease. So, Sasha, I will start with you again. What's your favorite regimen for standard risk, high risk, post-transplant maintenance?
Standard risk is typically lenalidomide. I think it's probably the most well-proven and beneficial agent. Long history, a long track record. For high-risk patients, I kind of waffle between lenalidomide and bortezomib based on AJ's data that Emory published years ago, but based on Griffin, I think it's also very reasonable to do daralenalidomide. Probably these days, I'm more often doing daralenalidomide only because it's easier to tolerate than the bortezomib, but I think either daralenalidomide or lenalidomide bortezomib are perfectly fair for the high-risk patients.
Ajay, what is your preferred maintenance, and has the Auriga study that was presented at IMS altered your practice?
This is a great question. So you ask 10 people, you get 50 different opinions, I believe. So the way that we have historically seen was standard risk patients and high risk patients. But we start to understand more about the flavors of myeloma, and 10% of all myeloma patients, they behave like extremely aggressive. This is the ultra high risk group. So I think we should start to see them as 3 different groups rather than 2 different groups. More is better. So there's no doubt, just like Sasha said, like that standard risk group, yes, you can get better PFS based on the Forte trial, based on every trial that uses a combination maintenance better than the len maintenance. However, do these standard risk patients really need that combination maintenance over a longer period? So we all agree that probably we can get away with getting a good PFS benefit with giving just the len maintenance. But if you look at the ultra high risk group, so which is the other extreme, we probably might need more than the PI and the IMID. So that's where the GMMG concept study has given, and the master trial has given us really good insights, as well as a MUC9 trial. All these saying that you have to combine the PI, IMID, and a CD38 antibody, potentially